I recently saw a male who was in his 70s, and he did not look like he was in his 70s. Very active, very functional, and even though he was retired, but he was now very active in his new hobbies of gardening and very active in the community. But recently he had seen that his walking distances had decreased a lot, and this was keeping him away from contributing to the community in a positive manner. He could not walk with his grandchildren. He could not play sports with them. And this distance where claudication started was getting was less and less. On the exam, I saw a very healthy-looking male. However, he had absence of pulses in his feet. And on the ultrasound, we could see that his ABIs had now dropped to 0.6. And 6 years earlier, when I saw him, his ABIs were 0.9 at that time. The ultrasound confirmed SFA occlusion on his ultrasound, and I made sure that he is on his best medical therapy with dual antiplatelet therapy, statins, and we attempted exercise therapy on him, but it was really limiting his lifestyle. Therefore, we proceeded with plan for angiogram and revascularization. My standard way of doing the procedure is contralateral retrograde femoral access and attempt for treating it from that same site. We obtain abdominal aortic angiogram and then perform selective angiogram of the affected side. In him, as expected with claudicants, his disease was mostly limited to the SFA and above the knee popliteal artery, where he had a focal SFA and proximal popliteal occlusion of around 10 centimeter in length. We performed systemic heparinization and then placed a destination sheet for up and over access. I was able to recanalize the occluded SFA and popliteal artery and re-enter in the true lumen. The entry into true lumen was confirmed by angiogram and also by an IVUS. IVUS helped me in determining the side which would need more atherectomy. I decided to use LS, which has a shorter nose cone and allows you for adequate treatment of P1 segment of popliteal artery, as your spider is present in the P3 segment. After performing atherectomy, I performed IVUS to make sure there's adequate decrease in the stenosis, and I don't limit myself with the numbers of passes required by 2 or 3. My goal is to make sure that the stenosis is less than 30% prior to performing drug-coated balloon angioplasty, or in the past, POBAs. So in him, after the IVUS, I had to do additional passages, and once the passages were done and confirmed on the IVUS that stenosis was less than 30%, I performed a drug-coated balloon angioplasty using an INPACT balloon. As you see on the completion, the SFA and popliteal artery are patent, and there's no residual stenosis. I did not require to place a bailout stent. After the procedure, I got a thank you letter from him and his grandchildren that he was back active in his sports and walking and helping the community.